Can you see it now?
Yes.
I just need to back up one or two more slides and I'm not, okay. Are you able to do that?
No, not when you are sharing the screen. Currently, you are sharing your screen, so you have to go back. You can use the back button. It's gone.
I'm sorry, I'm just having technical difficulties today. Let's see. And is it still sharing or no?
No, it's not sharing anymore. Okay. You can go ahead now.
Okay. So welcome and thank you for being here today. This presentation will focus on critical aspects of clinical research, the identification, documentation, and reporting of adverse events, AEs, serious adverse events, SAEs, and anticipated problems. This is a shared responsibility in managing.
Did they repaint the room? It feels they repainted.
This is a shared responsibility in managing these events, helps ensure participant safety, maintains the integrity of data we collect, and keeps us in compliance with ethical and regulatory standards. Whether you're a nurse, a coordinator, an investigator, or support staff, your role in recognizing and escalating safety concerns is essential to the success and integrity of any research study. I'll have you move on to the next slide. So the objectives today are we're going to define what an AE is. We're going to review an SAE, define an unanticipated problem, identify who is responsible for recognizing and reporting, understanding documentation and reporting requirements. We're going to clarify timelines and responsibilities and then review the role of the good clinical practice and why that is important and how this all relates to AE and SAE. You can go ahead and, okay. So we're going to start with an AE. An AE is an untoward or unfavorable medical occurrence in a study participant, including any abnormal signs, symptoms, or diseases, regardless of the relationship to the intervention. So the key points to this, it can be mild, it can be moderate or severe. It can be any symptom, sign, illness, or abnormal lab finding, or include an expected or unexpected event, and it may or may not be related to the intervention. It may occur during the study or during the study drug administration or after the study drug administration, and an AE must always be documented. So here's an example of what an AE would be. A participant is in a clinical trial. They take an investigational medication as directed, and later that evening they report on having a moderate headache. So the headache began after taking the study drug. It may or may not be related to the study drug. We don't know yet. And regardless of causality, it's an unfavorable symptom that occurred during the study. So an AE can include anything that is a mild headache to a change in lab values. They might have nothing to do with the study drug device being studied, but they still need to be documented and recorded. So an SAE then is a more serious event. An SAE is a subset of an AE that results in death, are life-threatening, require hospitalization, can cause disability, results in congenital anomalies, or otherwise deemed medically significant. Any undesirable experiences associated with medical intervention, like a drug, a device, or study procedure that results in one or more of the following outcomes. So there are 6 criteria for an SAE, which would be Did it cause a fatality? Did it cause a disability? Did it cause the participant to be hospitalized or a prolonged hospitalization? Did it cause an anomaly like a birth defect? Is it medically significant or was it life-threatening to the participant? So an example of an SAE, a participant in the heart failure drug study develops severe shortness of breath 2 days after starting the investigational drug. They go to the emergency department and are admitted to the hospital for observation and treatment. So this is an unexpected in severity, so it's more severe than just an AE. It requires hospitalization, which meets one of the 6 criteria for seriousness, and it may be related to the study drug. So I like to help remember the key categories of what qualifies a serious adverse event, and I like to use this mnemonic. So Fred doesn't have any money left, so which would be the 6 core criteria, and that's fatal, disability, hospitalization, medically significant, and life-threatening. Each of these words stands for a serious outcome that makes the adverse event reportable in SAE. So to help remember, if you want to use that mnemonic, I like to use mnemonics, but this is just one that you could use for that. And then you would know it would be an SAE and reportable. So that brings us to an unanticipated problem. So an unanticipated, an incident, experience, or outcome that is unexpected and related or possibly related to participation in research and suggests that the research places subjects to others at greater risk of harm than previously known or recognized. So according to the OHRP, a UP must meet all 3 of these. So it must be unexpected, where an AE or an SAE can be unexpected or expected. A UP is always unexpected, related or possibly related to the research, and suggests a greater risk of harm than previously known. So it has to meet all 3 of those criterias, then it would be an unanticipated problem. Otherwise, if it doesn't meet all 3 of those, it's either going to be an AE or an SAE. So I'm just comparing the difference between an AE and a UP. So like I just said, an AE, it's not always related to the study, but a UP usually is. An AE can be expected or unexpected, but a UP must always be an unexpected situation event that arises. And an AE does not necessarily increase the risk, but a UP, yes, it increased the risk to not only the participant, but it could also increase risk to others. And an AE doesn't, it depends on the severity and the criteria. So AEs are documented where SAEs are documented and they're also reported, and a UP must always be reported. So recognizing AEs and UPs. So I just gave a couple more examples here. A participant in hypertension drug study reports dizziness and lightheadedness 2 days after taking the medication. So this isn't an AE. And the reason why is the dizziness and lightheaded occurred after the study drug administration, regardless of whether it was related or not. And the classification of it, it's non-serious. And possibly related to the study drug itself. Now, if it became more serious and they were hospitalized, then that's when it would become an SAE. But right now, since maybe they, weren't hospitalized, the dizziness and that resolved, it still remains an SAE, or sorry, an AE, and it does need to be documented. For a UP, here's an example. A participant is mistakenly given the wrong dose of investigational drug, and although no harm could occur, or no harm occurred, this could have posed a significant risk. So this is a UP. And the reason why is the event was unexpected. So there's the unexpected in terms of conduct. It increased risk to the participants. So they put them at risk, but even though nothing happened, it still put them at risk. And it's related to the conduct of the research. So with them being in the research, it's related to that. So they do fill all three of those requirements, which then puts it at the UP. And you're going to always remember that you need to consult and know your protocol for specific guidelines for AE and SAE management. So the priority is always going to be participant safety is the top priority, first priority. You're going to provide clinical care per protocol, and if not contraindicated, ensure participant safety. And in emergency, the PI may consider consulting with the sponsor regarding the option of breaking the study blind if applicable. So basically, you want to follow the protocol guidelines. However, following the protocol, if it's not in the best interest of the participant, then you need to use your clinical judgment and override the protocol. So that would be an emergency situation. So you're going to follow the protocol unless it deems that this is getting serious. And then at that point, the protocol could be broke. Because patient safety will be first. I'm sorry, I didn't see that last one. So we're all responsible for identifying and documenting and reporting AEs and SAEs. You can go. So we all play key roles. So all clinical research staff involved in the care or monitoring of study participants share this responsibility for identifying and communicating potential adverse events. Adverse events may be identified through direct interaction, observation, clinical assessment, or participant self-reporting. So identifying and reporting these events is a shared responsibility. Anyone involved in the study can recognize and report any event, including the PI, the study coordinator, clinical staff such as nurses, lab technicians, phlebotomists, and then it can also be self-reported by the participant themselves. So this is a group effort, so everyone's involved. We work as a team, and we make sure that this information is always passed on, either documented or reported, so good communication. So let's break this down by looking at the responsibilities of each member of the study team, and we're going to start with the PI. So the PI is in charge of the oversight. So ultimately, they're responsible for reviewing all AEs and SAEs. Assessment. So they determine the severity, seriousness, and relatedness to the study or the procedure. And they're responsible for reporting. So they ensure that timely reporting is reported to the IRB, sponsor, and regulatory authorities. And then the study coordinator. So the study coordinators, they are responsible for documentation. So accurate records of AEs and SAEs and source documents and case report forms. They're responsible for communicating, notifying the PI of any AE and SAE, and that's immediately and not waiting. Follow up. And so they ensure follow-up information is collected and updated as needed. So keeping in contact with the participant if anything's reported and keeping that all updated. Submission, so assistance submitting required reports along with the PI to the sponsor and IRB per protocol and per regulatory guidelines. And then the CRC is also responsible, the Clinical Research Center, and that's the nurses and the coordinators. And this is the category which I fall in as a nurse. So we are responsible for observation and monitoring participants and documenting any observed or reported AEs. initial reporting. So again, prompt reporting any findings to the study coordinator or the PI. And we support the participant. We assist in any AE related assessments or interventions if needed. So a lot of times our staff, the nurses and the coordinators, the study coordinator may not be at the visit, and we might incidentally come across information from a participant. We're with that participant for 6 hours doing an IV infusion, and just in a conversation, they may have mentioned that 2 weeks ago they went to an emergency room visit. And so our first question always is did you notify the coordinator? And sometimes they have, and sometimes they haven't. A lot of times we've come across information where they've not reported because they didn't think it was anything and they needed to report it. So sometimes just in casual conversation, you'll get some information out. So at that point, then we would go ahead and report that information to the coordinator and the PI, and we would document it. And then the PI would decide the seriousness in that and whether it needs to be reported or not. And then the last is the data entry and regulatory staff. Not all studies have their own regulatory staff, sometimes just the coordinator, but data integrity ensures accurate entry of AE and SAE data into the EDC, so making sure that's all put in accurately and correctly. And then timelines support timely submission to regulatory bodies and to sponsors. So we know who identifies, but you need to know how to recognize an event. And this can be done through participant interviews. Sometimes that's through questionnaires. You come across some things in these questionnaires that you do with them. You can also find things through lab results, or you notice a change in vitals, or there's a change in their physical exam. You can also look in the EMR review, and sometimes you can find information there. Or sometimes the participant may report a complaint, either by email or directly while they're at their visit, email, phone call. They have a new symptom, something's changed, and the participant can report also. So again, this slide is kind of what I just went over. So the participant interview and conversation. So just sometimes in casual conversation and check-ins, participant may mention symptoms, side effects, or new diagnosis. So listening carefully and asking open-ended questions helps uncover potential events. By reviewing lab results, vitals, and physical exams. So comparing, blood pressure, maybe it's been running higher since they started in the study, or you notice a difference in the lab results, or on physical exams sometimes. Now they have wheezing in their lungs, stuff like that. So anything that's changed, I'll always report, or make sure it's documented and then reported to the PI. And then again, through the electronic medical record review. So we're reviewing the EMR for hospitalization, ER visits, or new medication can reveal events not directly reported to the study team, especially between visits. And then participant self-reporting. So again, like I said, they may email, call, or message with a complaint, such as like fatigue or pain or a new diagnosis. These always need to be evaluated and documented, even if they seem minor. So an AE is always going to be documented, but what you need to know what needs to be reported. So not only documented, but reported. So that's going to be based on the seriousness, if it's unexpected, if it's related or possibly related to the study, and any unanticipated problem involving risk to participants or others. So if they meet any of those criteria, that's when it becomes a reportable event. An event becomes reportable when it meets specific criteria based on regulations, the study protocol, and institutional policies. It may involve new or increased risks and significant deviations or serious outcomes such as hospitalization or death. Even events that do not cause harm may be reportable if they raise safety concerns or affect study integrity. So those 6 criteria that I had told you in the beginning, so if it meets any of those, make sure that you report it. So the rule of thumb is always going to be, if you're unsure, report it or ask. So let the PI know, let the coordinator know. And you can always, ask the IRB. It's better to over-report than it is to miss something that could be a serious issue. And then there's timelines for reporting, and this is very important, knowing your timelines. Timely reporting of adverse events is essential to protect participants and maintain compliance and regulatory and institutional requirements. The reporting timelines depends on the severity, expectedness, and relationship of the study. So, and not only for the safety of the participant, because sometimes depending on the severity of it, they may decide, let's stop giving the medication at this point. And hold it, but there's also a responsibility of the reporting that needs to be documented. So not only safety, but also knowing those timelines of, getting that to the IRB and letting people make decisions. So again, the AEs are non-serious, expected, and unrelated or unlikely related to the study intervention and are typically documented in the source notes and entered in the study's electronic EDC system, such as REDCap and other clinical trial databases. These events are reviewed by the principal investigator, because you're always going to let him or her know, but do not need to be reported to the IRB or sponsor unless it worsens, becomes seriousness, or meets the criteria for reportable events, such as an SAE or an unanticipated problem. So it will remain an AE until, unless it worsens and becomes more serious. And at that point, it's going to turn into an SAE that then needs to be reported and not just documented. And then criteria for reporting to the IRB, what needs to be reported promptly to the IRB. Again, it's the 6 criteria. A death needs to be reported, life-threatening events, hospitalization or prolonged hospitalization, persistent or significant disability, congenital anomaly or birth defects, or other events deemed necessary serious by the PI. So whenever you have any of these serious reports, then it promptly needs to be reported and not just documented. And so here's the timelines for reporting SAEs and UPs. An SAE must be reported promptly to the IRB within 24 to 48 hours or per your IRB. And UPs report to the IRB or sponsor within 5 to 10 business days. Again, that varies by IRB. And AEs are documented and not, they're documented and reported if the sponsor requires it. And if that AE then gets more serious, then at that point you would have to report it, and that would be within the 24 to 48 hours. And then there's a note, always remember your institutional's IRB specific reporting policies, site-specific SOPs, and sponsor protocols. Never use participant personal information when reporting, and you're only going to make sure, just like we do when we're identifying everything, once they have their participant ID, make sure that you use that ID, and you don't want to give the IRB or anybody that information, their personal information, their name or anything like that. So when in doubt, make sure that you report it to the PI. The PI is the one that's going to classify the seriousness of it and whether it needs to be reported or not. So if it moves from that AE to that SAE. So early communication helps ensure participant safety and compliance. So any event that is expected, possibly related to the study intervention and indicates a potential risk to the participant or others should be escalated. The PI's judgment on whether the event is related is key. But all study staff should communicate concerns promptly so that the event can be assessed and reported appropriately. So timely collaboration ensures regulatory compliance and participant safety. So there are some consequences for underreporting adverse events or unanticipated problems. So failure to properly report to the IRB sponsor or regulatory agencies can result in you could have a loss of the IRB approval. So IRB may suspend or terminate your study approval. It may delay or halt in participant enrollment and data collection. You may lose funding. It could be the investigator or the institution. And then if due to falsification, there could be criminal penalties or disbarment and suspension of ability to conduct the research at your institution. So make sure that you are reporting. Like I said in the previous slide, it's better to over-report than not report or under-report because there are penalties for not reporting or under-reporting these events. And then the documentation requirements are really important also. So you're going to use your source document and electronic data capture. Document AEs even if it's not reportable. It's really important to maintain accuracy, completeness, and timelines. And then you're going to clearly note the onset, the action taken, and the resolution of the event. And then what must be captured. So event details. So the description of the event includes the signs, symptoms, or diagnosis. You want to make sure you put the date of onset, and then if there was a resolution, the severity. So make sure you always document whether it was mild, moderate, or severe, and then the serious criteria, hospitalization or life-threatening, and then the outcome resolved, or if it's ongoing, or unfortunately, if it was fatal. Assessment of the relationship to the study. So whether the event is related, possibly related, or unrelated to the investigational product or study procedure. This is typically made by the PI. And then action taken, any intervention, study drug, whether it was stopped, medical treatment was given. So what did you do? And whether the investigational products was held, changed, or discontinued. And documentation location. So source document, this includes progress notes, clinic notes, EMR, nursing notes, and lab reports, case report forms, CFRs, and then electronic case report forms. Ensure consistency with source documents. AE and SAE logs, maintain an ongoing log of AEs and SAEs. And then correspondence make sure that you include any communication with the sponsor or IRB and the event, the onset of the event when you reported that event also. And you're also going to want to make sure that you keep a reporting log of the events and when they were first documented to the and reported to the IRB. So we're reporting timelines and follow-up, date the event was reported to the sponsor and IRB, documentation of follow-up dates, labs, and final resolution, updated SAE form in the event it evolves or more information becomes available. Some sponsors have their own SAE form, so find out if you do have an SAE that if they have their own form that they want you to fill out, so you would go ahead and fill that form out. Sometimes if they don't have a specific one, just include all that information that I had told you and give that information. Signature and attribution, so document must be signed and dated by the appropriate individual, such as the PI. Attribution of who identified and documented the event is essential for accountability. So what does good clinical practice have to do with all this? GCP good clinical practice is the foundation for conducting ethical and scientifically sound research. It outlines responsibilities for investigators, sponsors, study staff, including how to protect participant safety, ensures data integrity, and reports adverse events. Identifying, documenting, and reporting AEs and SAEs and unanticipated problems is not just a regulatory requirement, it's a core part of GCP compliance. Following GCP ensures we uphold the rights, safety, and well-being of the study participants at all times. So GCP and participant safety, good clinical practice. So ICH E6R2 defines GCP as ethical and scientific standards for research. It protects the rights, safety, and well-being of participants. It ensures credible data and emphasizes informed consent, monitoring, and documentation. So the beginning with GCP is the informed consent. So ensure participant understands the study. Consent form is like key here. You want to make sure that they understand the risks and their rights. So make sure that they understand all that and that they understand that it's voluntary participation and then there's no coercion. And then ongoing consent process. It's not just a one-time signature. Sometimes consents are updated, things are added as they go. Some studies last for years and they keep updating their consent, so they will need to have new consents as information comes out. So just make sure that participants are clear on what they're signing and that they have all their information and thoroughly review that consent. That's the first thing that you're going to want to do. Oversight by ethic committee, independent review protocols, risks and safeguard, and ongoing monitoring and safety and compliance. And then investigators must be trained and qualified. Only appropriately trained staff perform procedures and responsibilities clearly delegated and documented. And then safety. That's all right. All right, we'll just go back here. GCP is okay, confidentiality and data protection. Participant information is kept confidential. So again, going back to we remove their name and they are given a study ID. So confidentiality. Access to personal health records and data is restricted and monitored. Scientific integrity and protocol adherence. So ensure data are credible and accurate, protect participants from unapproved deviations or unsafe practices. So GCP is an international ethical and scientific standard that ensures research is conducted with integrity and respect to human subjects. So GCP protects participants by requiring that their rights, safety, and well-being are the #1 top priority. They are given clear, complete information through informed consent. Studies are scientifically sound and ethically reviewed by IRB. Investigators are qualified, trained, and follow approved protocol. And all data collection is accurate, verifiable, and confidential. By adhering to GCP, research teams uphold public trust, maintain compliance, and ensure that ethical treatment of all study participants. So in conclusion, some key takeaways. You're going to always want to document an AE. You're going to report SAEs and UPs according to the protocol and to the IRB guidelines. No GCP and site SOPs. And when in doubt, document and ask. And when reporting, never use participant personal information. Always use participant ID number. Any questions? Let's see if I can see this.
There is one question for you in the chat.
Okay, could you provide an example or examples of situations that are easily confused as SAE but are AE events or vice versa? So an AE is just something that may or may not be related to the study itself. It could be, it's usually, I mean, it could be mild, moderate, or severe. A participant, like I said, the example was it has a headache, and then they take some Tylenol and it's resolved. That needs to be documented. It needs to be documented that they had a headache and then rate the headache. Was it mild, moderate, or severe? And that they took some Tylenol and then it was resolved. It would become an SAE when that headache then progressed into, say, more of a severe headache. And now they needed to go to the hospital. They went to the ER and then they released and came home. They didn't find anything. It's the severity of the event that now took place. So in an AE, it's usually something that will resolve, that needs to be documented. Anything out of the ordinary, it's just going to need to be documented. Or if they usually do get headaches, and they did get a headache after the study drug, we don't know if the study drug caused that or if it's just their usual headache. That does need to be documented. But once it becomes more severe in any of those 6 core criteria, then it would become an SAE. Did I answer that question?
You did, thank you. Sorry, I'm coming off mute. So, because I have a follow-up question.
Okay.
And when it comes to an AE, is this only applicable to participants or it also applicable to samples, for instance? Let's say that if you collect samples from a participant, but you know the samples are compromised somehow, and you know based on SOPs, you know you have to report it, right? But does that apply to AEs? Do they only apply to participants, or it's also related to samples?
Right. No, you would always document that and report anything to the PI. That would need to be something that's documented. And then, you know, let the PI know. And then, like I said, they usually are the ones, they are the ones that are going to identify the seriousness behind it. But usually, sample would be probably just fall under an AE and not so much an SAE. Unless it was going to change the outcome of, you know, the participant itself, then that would become a more serious event. So, but that definitely needs to be documented. And then I would go ahead and let the PI know and let them know, you know, if it needs to be reported or not.
That's what I thought. Thank you so much.
Mm-hmm. And then what do you do if you have enough information to assess an event? For example, a person goes to another hospital and you can't get enough information about what happened. Rachel, do you mean like because since it's at another hospital, you don't have access to that information?
Yeah.
I mean, pretty much then you have to go back to the participant themselves and see. I don't know with Epic sometimes, depending on if you're able to, if you have, you know, in the consent that it's okay that you're able to look at this information. I don't know if you would be able to identify that through other hospitals. Sometimes they're all connected and it should be in there. But I guess if I'm answering your question correctly, if you can't access that, the only really way of, I guess, is the participant directly.
Yeah, thanks. I'm just thinking there are situations where you just don't have enough information to know how to categorize an event or report an event. And that's one of the examples that came to mind.
Yeah, yeah. Like I said, reporting is when it's more serious, and an AE is just really when it's something that took place, but it didn't affect the participant. And it usually resolves, but not always, but when it's serious, then you're gonna need to report that. And like I said, when in doubt, you could either call the IRB and see if it needs to be reported, let the PI know, and then the PI is the one that ultimately, makes the decision on the seriousness behind it. And kind of grades that.
Thanks.
Trying to read this one, sorry. Is it applicable to study one of the time samples, like blood donation for research purposes? I'm not sure exactly what you mean.
I'm asking if you need to report adverse events if, a picture pops up when you have like patient deceased, you get this notification that patient deceased. And then if this research is just for a one-time sample collection, but because we have to link them on Epic, they show up as our research participants. Do we still report that also?
So you're asking time, like blood donation for research. I'm still trying to get, I'm sorry, I'm still trying to get the question you're asking. So
So we have studies that the participants only donate blood, maybe
okay,
for genetic testing or even donate a tissue for whatever research purpose it's for.
okay.
And we go into Epic to link them to our research study.
Okay.
And that's it. That's just all they do. They donate their sample and we're done with that phase. We're not collecting longitudinal data or anything. Do we report anything if we get this notification that the participants died or anything related that they were admitted or something? Do we report that too?
So they're not receiving any type of medication. They're just donating.
Yeah.
Hmm. Um, I'm not really sure. Rachel, do you have any insight on this being IRB?
Yeah, that's a really good question. I don't know the answer to it, but I've looked at a lot of adverse event reports that came back when I used to work in the IRB, and there were a lot of situations where it was really hard to figure that out. My advice would be to contact somebody in the IRB office, explain the situation, and see what they say.
Thank you.
Sure.
Thank you. Yeah, I hadn't come across that, but that is really a good question. And yeah, I wouldn't know what to do in that situation, but thank you. Any other questions? All right, so just remember, documentation, reporting timelines, If you're unsure, like in this situation with that question, always call IRB and see if you can get some insight from IRB themselves directly. It's always better to over-report than under-report or not report at all. And always just remember, if it starts as an AE but progresses, it gets a little more serious, then that turns into an SAE, so that would need to be reported. All right, well, thank you if there's no more questions.
Thank you, Lisa, for the presentation, and thank you everyone for attending today. We will have our next best practice hour on Tuesday, 15th July 2025, from noon to 1. And please keep an eye out for emails regarding future sessions. Thank you so much.
Thank you.